Yes, we can. Okay, so Assalamualaikum and a very good morning to everyone, to Dr. Ahmad, Dr. Faiz, and all the participants. I am Dr. Razan Hayati Zulkifli from Department of Hematology, University of Science Malaysia. So our topic for case presentation today will be on the morphology assessment post-treatment in acute leukemia. So I'll be presenting 3 cases, and we're going to discuss. We're going to have a discussion on each cases later. So for the case 1, our main concern is that how we're going to assess treatment remission in a case of AML with monocytic differentiation. So this is a case of Mrs. NH. She is 55 years old Malay lady who presented to us with sudden onset right blurring of vision for 2 days after waking up from a nap. On top of that, she also had feeling lethargic, intermittent palpitation for about 2 weeks and had worsened for past 1 week. She also had complained an episode of epistaxis but resolved spontaneously, and also noted to have bruises over the trunk and also upper limbs. So on examination, patient was alert, lethargic and pale. Otherwise, no hepatosplenomegaly and drop space is resonant. So this is her timeline of the illness. So she was diagnosed in February last year, and during that time, our diagnosis was made as suggestive of AML, most probably AML M4 or M5, and then she had undergone induction. So upon completed induction 1 month later, clinically in remission, and bone marrow aspirate also we conclude as in remission, and bone marrow trifine we comment as no excess of blast. Query residual clonal blastine. So with that, with the clinical remissions and also our lab support, patient is remission, patient then continue with consolidation. And then, however, after completed consolidations, noted blood film show 27% circulating blood cells. So patient come again with relapsed acute myeloid leukemia. So she then was started on salvage chemotherapy, which MEC, and subsequently 1 month later, still marrow not in remission. And then with that, we escalate to flat IDA for this patient. However, during day 15 of flat IDA, she was pronounced dead, and the cause of death is E. coli and Pseudomonas aeruginosa bacteremia and in septic shock. So these are the diagnostic blood film, where we can see that there is 22% of blood cells, which are already suggestive of acute leukemia this time. And bone marrow aspirate, only 3 fine imprint was submitted, but there were homogeneous population of blood cells. And on the immunophenotyping, there are 2 population of cells, which are the myeloblasts and also monoblasts. But the percentage of myeloblasts is less than 20%, which are 12 to 17%. So correlating with the blood film, peripheral cytometries, trifine imprint findings, it is suggestive of acute myeloid leukemia. However, M4 or M5 cannot be excluded. So this is her diagnostic trifine, where there are homogeneous population of bloods with positive for CD34, 117, and PO and CD68. So this marrow trifine also suggestive of AML, M4 or M5. So upon completed induction, as patient clinically in remission, and based on the blood film, there are leukoerythroblastic with occasional suspicious cells, and the marrow actually showing marrow in remission as blast only 3.6%, but there are some degrees of hemodiluted. So based on trifine, we comment that there are presence of immature looking scattered small clusters of these CD34 positive and CD117 and CD68 positive cells. So generally, there are no excess of blasts. However, in view of presence of few small clusters of blasts, query residual, so we suggest for close hematological follow-up. So, however, after completed consolidation, patient come again with relapse. During that time, with 27% blood cells, and then marrow also fail, but there are hypercellular marrow, and then based on flow, around 29 to 35% blood cells. So this marrow suggestive of relapse AML. So following supported by this refined finding. So sorry. So I would like to invite Dr. Ahmad to share your screen for slide visualization. Waalaikumsalam, Doktor. Waalaikumsalam, Doktor.
Nampak tak slide tu?
Okay, nampak. Nampak, Doktor?
Okay, thank you. Okay, this is the case that Dr. Razan presented just now. How to make it? Okay, if you notice, this marrow remain hypercellular. You get here very few marrow spaces, but they are hypercellular even for his age. And if you go for further on higher magnification, okay, this is despite after receiving chemo, isn't it, Dr. Razan?
This is the diagnostic. This one is the
prior.
This is the diagnostic, the first refine, yes.
The first refine, okay. Okay, no, because to differentiate whether this is a post-treatment or diagnostic marrow is checking on the fat spaces. In post-treatment, normally or immediately after treatment, the fat spaces will be affected in the sense that because of stromal edema and also the presence of a proteinaceous material replacing the fat spaces. And here it looks like some of the fat spaces remain intact. So this can either be in a case of relapse case or it's a diagnostic case. In the case when you get the marrow without history. Okay, this is the hypercellular, even for any age. Kalau pediatric case pun, it is hypercellular. And if you go to higher magnification, you notice the normal hemopoietic precursors reduce. Okay. You see hardly any megakaryocyte, erythroid colonies, or grains with maturation. Okay, there are some grain with maturation, here and here. But then the predominant population is basically this kind of cells. This kind of cell. They are large. Some are, okay, they have double to triple to the normal resting lymphocyte. And they have conspicuous nucleoli, a high NC ratio. Okay, and this cell, if you notice, they are not really adjacent to any to the erythroid cells. This just to confirm that this blast not belongs to erythroid precursor or erythroid colonies. They are separated from those. Okay, and okay, this is the okay. If you notice, these cells are just quite numerous actually. They There's overpopulation of these cells, and now and the presence of these cells causing sort of suppresses the normal hemopoietic precursor cell. Okay, now we move to the immunohistochemistry. Okay, this is MPO. Can you see the MPO?
No, doctor. We see the black screen.
Ayo, sekejap ulang. Sekejap lah.
Okay, alright.
Share. Tukar another slide, dia tak nampak.
Buka slide lain dah.
This is new slide.
Cuba tu share balik ke tu.
Ni?
Kenapa dia X? Ni
Share this video. Okay, baik. Nah,
ikut ni.
okay, nah.
Cuba dah ke stop balik.
Okay.
Yang saya Dr. nak share mana satu?
Ni.
Share, tu share. Share the application. Okay.
You are showing the application.
Okay, nampak dah doktor?
Okay, thank you. Okay, this is MPO. If you notice, the MPO diffuse in almost every mirror spaces. So we know that this is a smyeloid series. Okay. Okay, they stain these cells. Okay, and here, if you notice, they are quite diffuse MPO, predominantly MPO positive. Yeah? Then we move to another slide. MPO, HNE, okay. We move to 68. Okay, this is the 68.
I'm sorry, Doktor.
Yes.
Boleh Doktor tekan yang the picture of the pembaris, Doktor, untuk for the image to be maximized.
Oh, okay. Okay.
Okay, Doktor.
Thank you. Okay, just now we saw the APO highlight the all the grand series, and under HNE on predominant blast, they are quite left shifted grand series, and here some of those cells here just focus on those cells with intact cytoplasms, not the reticular dendritic cells here. Just focus on this cell. Some cells, the larger cells, are expressing CD68 as well. So, okay, now we check on the 34 and 117. Okay, this is CD34. Okay, I put it under. Okay, if you notice, 34 quite abundant, I would say, and quite numerous, and some of the cells, not some, many of the cells are in clusters. Yeah, like this one, these clusters.
Doktor,
Okay.
sorry, we are seeing MPO, Doktor.
Oh, you are MPO?
Yes.
Oh, okay. Yes, okay, share this video. Okay. This is a CD34. Okay. So this CD34 under low power also already sort of telling you that patient is in the ischemic phase, because you have quite plentiful of CD34, and on higher magnification, you notice that some of these 34, many of these 34 actually in small clusters. They are this one is a 5 cells clusters, 3 cell clusters. Many are in clusters form. They are not sprinkled individual cells, but frequent cluster formation. This cluster formation with plentiful 34 expression is already confirmed that this is acute phase. This cluster pattern, I just quote what the Prof. Babarabin mentioned. It is very useful, to indicate either patient is not in remission, or a patient in early relapse. Is previously patient was okay on treatment, and then suddenly on follow up Bero with a few 34 positive, but then expressing 34 in clusters. That 34 pattern indicate early relapse, or not in remission. What more? You have clusters plus numerous 34 expression in the background. So this is a case of acute look, and we move to 117. This is another marker for immature cells. This is 117. Yeah. Okay, this is 117. Okay, so 34, 117 also confirm the blast expression as in 34. Well, this is a case of acute leukemia, acute myeloid leukemia. Okay, now between the population of myeloid and
Sorry, Dr. Ahmad. Kita tak nampak ada CD117 sebelah ni.
I panic ni. Tak ada
Ini
assistant.
sekejap.
Okay. Can you see it now? Tak dapat
Masih gelap.
Alamak, share this, share.
Okay, nampak dah. Right.
Lambat je. From
Nampak dah.
dia kena cross South China Sea dulu.
Nampak dah.
Okay. Okay, this is the 117. Quite similar in terms of forming clusters of 117. Similar, confirm the CD34 just now. So we know this is acute myeloid leukemia. And because just now when you check on CD68, there are presence of similar cells. So likely that this is a case of M4. M4. Okay. So we have discussed HNE, MPO, 17, 68, 61, and 34. Okay. Then we go to the next case. Sorry, next case. Yeah.
Yeah, for assessment of next assessment post induction is T7422. Doctor.
Saya.
Okay.
Okay. This is a post induction. Okay, this is a post-induction marrow. If you notice the hypercellular patches remain here, and not much improvement, so only minimal improvement post induction. But we are suspecting because of the hypercellular background, there are some residual disease here. And then Razan, this is a post-induction. How many days after completing the first induction? The induction.
So this one is 1 month after completed induction.
Oh, 1 month. So
Around yes.
So kalau 1 month, I mean, looking at under low magnification, the presence of cells in the background quite hypercellular, but now they have already showing matured adipocyte, the fat spaces. So after 1 month, normally in the normal marrow with classical post-induction marrow, normally after 1 month, the marrow will fully recover. I mean, provided they are showing responded to treatment. So 1 month, they have completed marrow have been fully recovered. Meaning you can get the normal cellular marrow with fat spaces, and then you get erythropoiesis, granulopoiesis, and last would be presence of megakaryocytes. So we have to look at those features if there is evidence here in this marrow. Normally within 1 month, within 2 to 3 weeks post chemo, you still have some degree of marrow edema, proteinaceous material in the background, and reduce marrow spaces. But after 1 month, normally you can get normal marrow. Okay, here. See. I'm looking for mega. Okay, there are some occasional mega, but if you realize now the number of redshifted grains is becoming more common in this field, in this marrow. Yeah. Okay, you get here neutrophil here. Okay, and also appearance of mega, but at the same time, you can still appreciate a few blast-like cells, similar features as in the earlier marrow. Okay. More maturing grain series. Try to look for mega becoming more common now, but I'm looking for the airy colonies. Okay, here you get all the grain series maturation, because in recovering or regenerating marrow, but not like common in this marrow. Okay. So because of neutrophil maturation, so we are suspecting that there are some marrow improvement, marrow regeneration, and improvement to the treatment. But we need to be careful on this particular immature cells, whether they are still expressing 34 and 117 to indicate there are some not in complete remission. Yeah? Okay. Now we move to the next slide. HNEMPO. Okay. I think we can jump to 34, 34 and 117 first. Okay, 34. You have here 34. Okay. 34 appears markedly reduced, but there are some positivity on individual cells. Yeah? On individual cells. Okay, if you have few 34 positivity, okay, and then predominantly individual, and occasionally you encounter two cells clusters for this one, then you have to weigh between you have to sort of, this is the gray area, whether you want to consider as incomplete remission, or actually patient has already in remission, and this 34 you have to check with other sir, 34 with, if possible, you get TDT, because in post chemo, for example, you may get some hematogons, circulating hematogons. Huh? Okay, even in this the hypercellular area, hardly any 34 positivity except here, but this could be some technical error here, because if you notice, the cell here, the nuclei in this area, as compared to here, this small foci, the nuclear of this area appears more, more sharper, and it's not as hazy as this area, isn't it? It could be some technical error here due to during the antigen retrieval. Maybe some technical problem here. Okay, if you notice these cells here are more crisp as compared to this one, which is a bit hazy looking. Yeah? So it's a bit difficult to assess on this one, but on whatever areas, the exhibition 34, they are all mostly individual cells. Only occasional you have this two cell cluster here. The remaining are individual 34. And if you to semi-quantify from the previous one, there is a definite reduction in 34 positivity from previous probably now reduced by more than 80%, isn't it? Okay, 34. Now we check on the CD117. Okay, this is CD117. It shares a similar pattern of individual cells. So in your report, you can sort of semi-quantify and also the number as well the pattern. Yeah. Okay. In your report, then you have to say, okay, 34 and 117 appears markedly reduced to more than 75% or 80%, and this the semi-quantify the pattern, and these cells are held distributed individually with very occasional two-cell clusters. Okay, this indicate okay. Then check on erythroid if any. Oh, we didn't have the erythroid. Okay, because we need to check on erythroid just to indicate there are the rest of the cells are showing erythroid regeneration, because under HNE we saw megakaryocyte just now. But as I think based on the 34 and 117, because previously it was positive and very markedly positive, now the number of 34 and 117 has significantly reduced, and they are all predominantly in individual cells. So it looks like that this time patient has improved with treatment. Sorry. So next on T3522, Razan.
For this case, actually, this is the last one.
Okay.
So 32 is actually the diagnosis that we have go through just now. And then this one is T7422. Is the last for this case.
Oh, I see. I mean, so if looking at this post-induction, after 1 month post-induction treatment, it looks like the treatment has managed to sort of eradicate the blood cells, and what we saw just now, just residue. It's a bit difficult to say whether this is residual, because we need to check. Okay, we need to check with compare this 34 with TDT and also B cell for the possibility of hematogons. Even though it's this elderly patient, you can still get the hematogons post chemo. And then the pattern does not really support residual disease here because of infrequent clusters, and clusters is only 2 cell clusters, very occasional 2 cell clusters. Okay.
Doctor, the CD68 for this sample, doctor?
Okay. CD68 we can CD68 might be increased in this case. We check first. Okay, this is 68. You have very few 68 here. The problem with 68 post chemo, because 68 will be within 1 month. Within 1 month of last chemo, 68 will be increased. That's a part of the recovery. You have erythroid, you have grands, comes together with 68, but they are all matured 68 or differentiating 68. And then probably during this time, if you do 68, you break down into CD14 and CD163, you might get more of the 68 expressing CD14, meaning that these are the matured type or differentiating type of monocytic cells. Yeah? And here you have a few here. Again, they are not really forming clusters. You might also wondering, then what about the pattern, doctor? Because somehow they tend to localize in some area. But then they are not really forming clusters. As you see here, they are individual cells. So it be difficult to ascertain whether this is 68 of malignant cells or not. But then they should express 117 if they are a blast. Because previously it was both 34 and 117 positive. And for assessing the post chemo marrow is not only assessing on the residual disease, but we must also do immuno on the regenerating to confirm the presence of regenerating component. I will discuss with you in my PowerPoint very soon after this. Yeah. So if you have this kind of pattern in focal under low power, okay, you get this loose groups of 68 positive cells, not in few areas, and you are probably you can add it in your comment. So the presence of this loose aggregates or loose clusters of 68 positive cell does not unequivocally exclude residual disease, because monocytic leukemia, the monocytic itself rarely express both 117 and 34. It is the myeloid component that express. So if you have suddenly a discrepancy between 68 and 34 and 117, 68 versus 34 and 117, then you have to proceed with CD14 and CD163 just to confirm whether they are of the maturing or differentiating type, or they are remain in the immature form, which is normally expressed by 163. Yeah. Okay.
Okay, Doctor. So I think we can open for Q&A. There are some questions at the chat box.
Okay.
So first, from Dr. Nia Hafiza, commonly on post-induction marrow, we'll see increase in erythroid, but for this case, erythroids are not well represented from H and E. Thus, should we be worried? Should this observation also include our guarded impression? And also, whether would you repeat the CD34 and CD117?
I think instead of repeating 34 and 117, I would like to confirm with immuno for ecaidarine and also glycophorin A or C. And this is because we need to immunohistochemically confirm, not only by H&E, because H&E we are limited by sometimes the staining pattern, like in this case, you have just now I mentioned here, the one that express like here, the one that express 68, they have more clearer, darker nuclei as compared to the adjacent one, which is more hazy. So we are just wondering whether there are some problems, incomplete deparaffinization during the antigen retrieval that makes them does not pick up the staining. They look quite hazy here. So first we have to confirm those erythroid.
Okay, so thank you, Doctor. So another question from Dr. Dardina. Salam, Dr. Ahmad. Is CD163 helpful in this case?
Yes. 163, if you notice, but then during practice, when practice, you will find the CD163 will also stain the dendritic, the monocytic dendritic cells. So, but then you just focus on okay, now for the monocytic cells, monocytic series, if you rely entirely on 68, CD14, and 163, it would be very dangerous. But then the guide is you must first look at HNE, and preferably on the thinner section, and must observe the presence of atypical cells. That atypical cell, just to confirm that either they are myeloid or monocytic cells. The presence of those atypical cells must be first observed on HNE. Then you proceed to the stain. If the staining they express 68, they are normally, classically, and theoretically, they are 68. Pen 68 will be positive. But then when you stain with 114 and 163, then you can see the differentiation. 163 will stain more towards the immature one, and 14 will show the matured one, meaning, or they are showing differentiation. So in this case, they are really helpful to have 163 and also 14.
Okay, thank you so much, Doctor. That's actually really helpful. So CD163 is for the more immature monocytic precursor, and CD14 is for maturing monocytic.
Yes.
Series. Okay, another question, Doctor, from Dr. Farah, regarding CD117 interpretation, particularly on follow-up marrow. Can you share how should we interpret it, as there's always background staining and their positivity on the cells much lesser intensity? How to differentiate it, whether it is background stain or positive staining cells?
Okay, 117 will stain the cytoplasm, isn't it? Just like CD34. But then the CD34 stain having the granular pattern on the cytoplasm, but not for the CD117. Okay, interpreting CD117. The literature doesn't mention about that you have to be on specific pattern, just like when you are interpreting PD1, for example, because they have criteria in interpreting PD1 for angioimmunoblastic T-cell lymphoma. But in this case, CD117, as long as they are cytoplasmic staining, then we take it. Whether this is intense or moderate, as long as they're confined within the cytoplasm, then we have to take it as positive. The intensity is not a requirement. But you must remember in CD117, especially when you have CD117 larger or more as compared to CD34, because you can get in immature regenerating erythroid. You can get in plasma cells. So in post chemo, post induction marrow, you have erythroid regeneration, isn't it? So then you must think the possibility of actually they are staining the immature erythroid, which you can confirm the erythroid by having ecadorine. So if suddenly you get if some of this 117 forming 2-3 cell cluster, and you compare with ecadorine, if they are similar to ecadorine pattern, then likely those 117 are actually belongs to immature erythroid in post chemo. If having compare with ecadorine, they are, you can exclude whether this is actually true residual disease or actually being contaminated, being false positive from other cells.
Okay, doctor. So CD117 should be regarded as positive if it's cytoplasmic staining, regardless of the intensity, right?
Yes.
And as you mentioned, it can be seen in regenerating area. So that is another reason why we should do ECAT and glyco
Yes.
to show that there's this actually regenerating marrow. So
Yes.
in that note, can I ask whether should we have done TDT and PAX5 on this case for hematogons?
Yes.
Okay.
Definitely. Definitely.
All right. And also, we have another question from the participants, from Dr. Wan Zuhaira. Do we need to mention the reduction of 75% to 80% of blood cells compared to the previous diagnostic marrow in our report? Do we need to quantify the reduction, Doctor?
That would be a better practice, because at least it we can relay the message to clinician, the who managing the case, that the treatment is that they are managing the patient on the right track with improvement. So they can either, if patient hasn't completed the treatment, they can continue treatment. If after 1 month, for example, on induction, suddenly okay, there are some residual disease. Comparing to previous one, there's only say 40% reduction, for example. Then they have to plan on other options of treatment, because after 1 month after on induction, actually the 60% of tumor load still present in that marrow. So not the classical, not the expected outcome that, for the classical treatment. So it's good to for us to semi-quantify. This is not accurate, but then you can give some assessment, and that will give you give some sort of direction to the clinician now. One is cellularity. So if the cellularity sort of in the post-marrow, post-induction remain hypocellular, for example, and then what causes the hypocellularity? Is it residual disease, or actually marrow is regenerating? If they become normocellular, is there any residual disease? So say, for example, you have 10 marrow spaces and suddenly only 2 marrow spaces appear hypocellular when the rest are already normalized. When it's normalized, what are the percentage? That you can semi-quantify.
Okay, Doctor. Thank you very much for your opinion. There are 2 more questions, but however, I think these questions would be more relevant in our next case. Dr. Zuhaira, our next case is actually about your question. So, Dr. Razan, can you please share your screen and present the next case, please? Thank you.
Okay, for the second case, Can you see my screen?
Yes.
Okay, so the second case is actually mainly assessment of treatment remission in a case of AML with monocytic differentiation where CD34 and CD117 are negative. So this is a case of Mrs. S. She is 32 years old Malay lady, para 0+1 ectopic, who had been unwell for the past 1 month and presented with us with periauricular pain. So she had been complained vomiting for more than 10 times with headache, myalgia, arthralgia, and noted to have leukocytosis. So on examination, noted that patients are lethargic, dehydrated with coated tongue, and there are enlarged tonsil with multiple cervical lymph node with a liver span of 14 cm and otherwise spleen are not palpable. So this is her timeline. Basically, the diagnosis was made in July last year. So the diagnosis of AML with monocytic differentiation was made following the flow cytometry and also trephine biopsy. And she was started on induction, AML 3+7, dose adjusted. And post-induction, noted there is an excess immature cell with monocytic differentiation. So with this, patient then re-induced back. And upon completed reinduction, there are no excess of blast. So patient then continue with consolidation, HIDAT cycle 1. And then 1 month later, the marrow still not in remission. She then escalate to flat IDA. Then while on plan for flat IDA actually, but it was pronounced death 5 days later after our report release lah. So the cause of death is cerebral hemorrhage with IVH. So this is the diagnosis where we can see that majority of the, based on the blood film, majority are the promonocyte, which are 50%, and blast of 5%. And based on flow cytometry, we can see that 0.8% of monoblast, 50% of promonocyte, and the rest are monocyte. So based on this, the findings are consistent with AML and 5B. Based on trephine, we can see that those cells are actually fluoride positive for CD68, lysozyme, and MPO. However, they are negative for CD34 and 117. So for this, we had CD99 add-on to confirm the immature precursors. So subsequently, post-induction, based on the blood film, there are pancytopenia with no circulating blast and fail to get marrow aspirate, so remission status cannot be ascertained. And on trephine biopsy, because we did CD99 at the first diagnosis, and on this current trephine also we did 99, and those 99 are arranged in small clusters. So we suggest that there are presence of excess immature cells with monocytic differentiations. In view of this megakaryopoiesis, so transformation for MDS MPN need to be considered. So these are the blood film post reinduction, where based on the blood film there is occasional blast cells and bone marrow aspirate. Still, remission status cannot be ascertained due to hypocellular marrow. And from trephine, we can see that hypocellular marrow with no excess of blast, as we quantitate the blast generally less than 5%. So, however, after completed consolidation, patient then come again, showing 90% of blast and blast equivalent from the blood film, and similar to the bone marrow aspirate, where this finding consistent of marrow not in remission. So mainly for this case, our assessment of remission dilemma is that how are we going to assess remission in a case of CD34 and CD117 negative blast cells. Dr. Ahmad, can you share your screen for our next case?
What? The
The folder is S. And then the folder is S, and the first number is T16122.
Okay.
That is the diagnostic.
Sorry. Okay, this is the diagnostic mirror for Mrs. S. Okay. Hypercellular throughout. We know this is definitely patient in the is having leukemic phase. And first thing on this hypercellular mirror first, we must check any residual hemopoietic cells, precursor cells. There are few mega here, very individual mega. Grains, the grains with maturation appears hardly seen. Same goes to the erythroid colonies. So the normal hemopoietic precursors are being replaced almost extensively by the these cells, no? And these cells, they varies from round shape, all actually displaying vesicular nuclei, with some with conspicuous to large nucleoli. And the other is from round shape to having a large cell and with indented monocytic differentiation. Here, here we have cells with indented with monocytic differentiation. Yeah? But they are predominant cell plus, they are having quite brisk aberrant mitosis. Okay, they are having monocytic differentiation. Okay, quite easy. It's a good section, thin section. And this one is this is acute leukemia, probably with monocytic differentiation. Then we move to MPO. This is MPO. Okay, there are some residual paratrabecular MPO, but the rest has been markedly depleted. So it looks like the predominant cell with morphology of monocytic morphology is occupies predominate the spaces, the mirror spaces. It looks like they are M5 rather than M4. Okay. This is MPO. Now we move to 68. This is 68. Okay. You don't need to have 163 or CD14 because we need to just confirm the lineage that they are monocytic cell. So it looks like quite very diffuse. Very diffuse 68 positive. It's then almost all cells. So then we know this is we are dealing with M5. M5 and then J34. In the classical acute M5 leukemia, this is known for the fact that there are 34 and 117 negative. Yeah? This is CD34 negative. It, 34 just highlight collapsed blood vessels. At least we know they are working. The staining. Okay, just collect blood vessels. In fact, if you notice, some cells of similar cells are present also intravascularly. Here, okay, intravascular cells present. This is 134 negative. 117 this is a CD117, also completely negative.
Sorry, Dr. Ahmad. This is CD34 from the slide.
Sorry. Sid, also CA. CD117. Okay, you get the CD117 negative. Boleh nampak tak?
Boleh Doktor?
Boleh tak?
Okay. Okay, this is CD117, completely negative. Now we move to CD99, is the immature marker for any cells. Okay, this is CD99. Is quite reliable when you in this context because we know HNE shows all blasts, isn't it? Using CD99 in this context quite okay. I mean, CD99 is not specific. They just indicate the immature cells. So, but then in post chemo, when assessing, say you don't check, you don't really review the HNE, using CD99 as an indicator for residual blast would be very dangerous because in regenerating marrow is the place where you get all immature cells, be it in the plastic or regenerating marrow. So the CD19 will also highlight those immature cells. Then you have to compare with other markers, just to confirm that they are again CD68 positive. If you don't have other markers, 163 or CD14, for example, you can use with precaution, with cautious. Meaning you compare that 68 and 99 expression has to be almost steady. Okay, this immature because this is just indicating of immature cell. This is CD99. So here we have 34 negative, 117 negative, but they are expressing CD19 positive. And with that, this actually just confirm the 99 confirm the HNE of blast monocytic series. We have CD99 here, and let me check the what's LEM1? Lysozyme, right?
Yes, the lysozyme, lemon lysozyme.
Okay. Okay, this is lysozyme. Okay. If you notice, the lysozyme standing pattern quite similar to what CD34. They have cytoplasmic with granular staining on the cytoplasmic membrane, and they are granular. So okay, this is again just indicate there are most of these cells are monocytic series. So this is M5, and the refined biopsy cannot subdivide whether this is MA or M5A or 5B. What we know is this is AML M5. Okay.
So, the next case, the next slide is on T18622 post induction. 186.
Okay, this is a 186 post induction HNE. Okay, post induction. It looks like that the marrow remain hypocellular, but only slight reduction in the cellularity. But in overall, every marrow species are still hypercellular. And see what are those cells. Okay. Then here we have a grand series with good maturation. You have mega, but where is the erythroid colony, which is supposed to be the first to appear? Forget about this because unless they are frequent, then we have to consider some of these plastic changes. But in post-chemo, then you expect to get all those changes, some dysplastic changes. Couldn't really appreciate the erythroid colony so much. Yeah. So they are hypercellular. Probably you can see here some erythroid colony here, and also megakaryocyte, individuals megakaryocyte. Okay. Okay. If you have CD99 here, because apart from grains which shows maturation, and then the remaining cells are probably regenerating, then you have to be very careful in interpreting CD99. Sorry. You still have patchy areas of hypocellular marrow. Check on CC8.
Dr. Ahmad, yang based on H&E ni, yang above there tu is area of necrosis, is it? Yang the pinkish materials.
Yes. This is what we call the proteinaceous material replacing the fat spaces. This is commonly seen in post-chemo. So sometimes you get the transition of post-chemo changes here. We got the stromal edema actually being replaced by proteinaceous material. They are sort of obliterating the fat spaces. And then if they are predominant, then okay, just indicate they are post-chemo changes. Then after this, then you get followed by erythroid colony. This is in chronology, in step changes. After this one, then start to marrow regeneration by presence of erythroid colonies scattered. Then appearance of fat spaces, the new normal fat spaces, followed by granulopoiesis. That's so here we have two features, two components. You have patchy areas of residual post-chemo changes, and also regenerating marrow here. Some of these hypercellular are actually being composed of erythroid colonies together with here actually megakaryocyte is already present. Okay, you have here colony also generating granules. Okay, type of with this but to some degree, the marrow is showing uh, some reparative or regenerative changes. This is okay. Can you see the 68?
No, doctor. We're seeing the LAMP one.
Oh, yes. Sorry.
This one.
Okay, this is 68, isn't it? Okay, 68. 6. Okay, so. Okay, here. 68 quite significant. Quite significant number of 68 positive in those hypercellular area. So sort of it gives us a suspicious of residual disease, despite marrow having regenerative changes. Here and here. But then we have to look under higher power. Okay, quite dense aggregates of those CD68 cells here. But then remember, 68 alone in post-chemo can also be seen in recovering marrow, because in recovering marrow you get macrophages as well as edema, and also those especially in area with proteinaceous material. Okay, so it's good if we can use other markers, for example, 14 and 163. If not, then probably you have to compare this area, this hypercellular area of 68 positive with CD99, and make sure, remember, because in hypercellular area just now, we saw erythroid colony and also mega as well, isn't it? So when checking on 99, you have to sort of, the mapping must be on, especially on this area. This area. Okay, we check 99. Okay, this is 99. This is a area with 68 positive just now. And on diagnostic mirror, we saw 99 are equally expressed in as numerous as CD68. Here you have very occasional cells with complete cytoplasmic staining here. For example, this is one. This is one. There are not many actually. What about the flow, Dr. Razan?
So yang this one, actually we are unable to get the mainly the cell trays are partially clotted. So
Okay,
we are unable to get the flow cytometry samples
I see.
due to partially clotted specimens.
So there's no flow result on this one to compare with.
Yes.
Okay. If you ask me on this marrow, I don't feel safe to pass it as there are some still residual disease with this 99 pattern. 99 pattern. And I will normally proceed with 14 and 163 plus checking on the erythroid colony as well.
I see. So we can't just depend on CD99 expression, right? That the have
Yeah,
to do
because
the
in post chemo, remember post chemo there are two patterns: residual disease, if there is any, plus regenerating marrow. And all both are immature cells, right? And the CD99 happily pick up all those immature cells. Then we might be sort of it gives you some false positive pattern. Thinking that there are many CD99, but actually the immature, the precursor cell, originating cells are also expressing 99. 99 is not specific; they are sensitive for immature cells. So in the safe practice is that's how we should interpret 99 in post chemo lah. Be aware of regenerating cell. So you have to compare. You need to if you don't have other markers for this monocytic series, then we check on what Icadorine and also Gly A. That one for immature erythroid colonies. Because just now we saw two patterns. Yeah? In general, we saw patchy areas of proteinaceous edematous stroma with proteinaceous material and a predominant recovering, sort of regenerating marrow with normal adipocyte fat spaces and also erythroid colonies and breast mega population. So actually we are receiving marrow in the at the interface between full recover or we carrying some tumor plus minus tumor cells lah. So we need more markers to confirm the presence of those tumor cells. Okay.
Okay, thank you, Doctor. We have several questions.
Okay.
But I think because we are running out of time, we'll go to the third question and then go through your presentation at the end. If we are unable to answer the questions given by the participants today, we will email to you the questions and maybe you can answer it in your own time. Doctor?
Okay, no problem.
Okay, all right. So I would like to invite Dr. Razan for the last case.
Okay, so our last case, I'll share. Case, yeah, that we get here in English, a case of BAL where actually they are following consent. Majority of the kids within the activity are always arranged in clusters. So how you go about it? So this is a case of 10 years old boy who presented with sudden onset of central chest pain and noted to have multiple cervical, submandibular and inguinal lymph node. He also had hepatosplenomegaly, and this is his timeline, where the diagnosis was made in April last year. And in the mid-induction, he had pancytopenia with occasional circulating blasts, but the trifine imprint are still excess of blast. So he's continued with induction. Upon completed post-induction, clinically, there's still presence of hepatosplenomegaly and the count still not recover yet. And BMA also only imprint based on the trifine marrow not in remission. So with this clinically and also supported by laboratory that the patient is not remission, then the clinical start escalate to regime C for consolidation. So for consolidation, what we can see here that after completed consolidation, the blood film still pancytopenia, the bone marrow still cannot be ascertained, and based on trifine, there are no excess of blast. So he then continued with delayed intensification and clinically in remission based on clinical justification. Blood film also no blast, and the remission still failed due to hypocellular marrow. But from the trifine, we conclude that the trifine most likely marrow not in remission. So, but clinician continue with the current treatment as based on the justification that the patient is still in remission clinically. So after completed maintenance cycle 1, last March, clinically also in remission, blood film and marrow supported that patient is in remission and trifine also in remission. So basically this is the trifine where he presented with 28% circulating blast, and then based on the marrow and immunophenotyping, supported that this is suggestive of acute BALL, and followed by fluoride positive for CD34, TDT, and PAX5 based on trifine. So this is the mid-induction where pancytopenia with circulating blast and the marrow is inconclusive for interpretation. But from the trifine, we can see that there are large clusters of CD34 and TDT. So we conclude that there are excess of blast cells. Post-induction, clinically, patient still not in remission. And then based on the blood film, there is biocytopenia with no blast cells. And marrow also suboptimal for interpretation. Following trifine, we conclude that the marrow is not in remission as there are large clusters of CD34 and TDT cells, which are more than 5 cells. So patient then escalated to regime C, where based on the count still not recover, and based on marrow also remission status cannot be ascertained, and then based on trifine, we conclude that there were no excess of blast as scattered blast cells highlighted by CD34 and TDT. So our main concern is here when after completed delayed intensification, while patient is actually in remission, the blood film is also supported that there is no circulating blood cells, the count are recovered, and then based on the marrow, as it is still patchy hypocellular, so remission status cannot be ascertained. But within this hypocellular marrow, the blast is around 3%. And then based on the trifine, as there were increase of these immature looking cells, although they are following hematogon pattern, but we conclude that most likely marrow not in remission. Okay. So I think we can go to the cases, his case.
What's the number, Dr. Razan?
Okay, his folder is NMA.
Okay. So you
And
have 5.
The number one, Doctor, yang
T71, eh?
371 is.
Okay, diagnosis.
Yang
Is
the
that
first one, T7122.
Okay.
That is the diagnostic memory.
Actually, yeah. Okay. Okay, this is the marrow, hypercellular. We have no problem in the diagnosis here. Hypercellular marrow with depletion of normal hemopoietic precursor cells. And the cells are large mononuclear and displaying fine chromatin and conspicuous or too large nucleoli. They have large and medium size. Looks like macam sorry. Ish. Sorry. Okay. Hardly any residual hemopoietic precursors. They are cells. Okay. And this agree by H&E, it's a case of acute leukemia. And now we move to
Maybe we can move to the T2223, the one that based on clinician they agree that the patient is in remission, but and even our count also recovered with no blast. But based on the tree find, we can see that they are following hematogont, but the TDT is actually in small clusters.
Okay.
T2223.
Okay. Maka disembihkan. Okay, this is the, just before we move to the, okay, before we move to 2223. This is the TDT for the cell, for the diagnostic marrow. They also diffuse, and this is confirmed that this is a case of acute look. And we move to next slide, 2223. Oh, sorry. Okay. Post chemo.
2223 is post delay intensification 1. Delay intensification.
Okay, this is the. So if you notice, the TDT pattern has changed quite significantly. Now we have just sprinkles of TDT positive cells. Okay. It looks like the cellularity has also normalized. You get more fat spaces here. We are cut short from just now, from ball just now with dense TDT. Now become sprinkles of TDT everywhere, but they are not forming clusters anymore. So, okay, now this is TDT. And hardly any. If you do encounter some clusters, say for example this one and this one, you must take in overall, or what the predominant features here are. They are scattered individual cells with only occasional clusters. Then likely that this one we are dealing with suspicious more of hematogones rather than residual leukemic disease. So when you get the kind of the TDT pattern, so now we have to compare. What's that? PEX5. Okay, this is a PEX5. PEX5 may follow TDT. Okay, this is a PEX5. It follows TDT, isn't it? Because PEX5 are more immature B cells. So they follow TDT pattern. And this is CD34. What can you comment comparing 34 and TDT? So 34 is much lesser than TDT, isn't it? But comparing 34 and TDT, you must compare diagnostic and also was that post induction? Because if the previous one, because not all acute look will be TD34 positive, so we have to actually compare with the pre-induction 34. But when you semi-quantify the 34 and also TDT, you will notice here under low power that 34 is much lesser as compared to the TDT just now. So the one more markers that will help you to confirm whether this one is actually residual or hematogone is actually by having CD20. Then we will expect CD20 to be far lesser than PEX5, because PEX5 and 79A would be similar marker of the immature cells. They can cover immature cell and also the mature cell, but CD20 will only express in more differentiating, the more mature cells. So what's the The TDT pattern would be PAX5 positive, PAX5 equal to 79A equal to CD10, and then then there are CD10 more than TDT, more than CD20, CD20 more than TDT, TDT more than 20, 20 more than 34. That pattern lah. Follow. So looking at this one, its features are likely to be hematogons. If you get one or two cell clusters, fine, because you have brisk hematogon. What Prof. Bain mentioned was when you are dealing with, say, 5% blast on Trifine, then the pattern of clusters are become very, very essential. Because in hypo, with the very few blood cells, then they are still able to form clusters that indicate incomplete depletion. But when you have a brisk population of TDT, like in this case, and suddenly only occasional one or two clusters, when the rest are actually individual cells, then we would towards hematogons.
Doctor, we did CD20 additional last week for this case. For this Trifine actually. So I can see here that this is his CD20.
Okay.
Where actually lesser than TDT, and there are actually sprinkles of CD20 here.
Okay.
Not much as compared to TDT just now.
And also PAX5 kan, it's much lesser than PAX5 kan.
But so, actually when we encounter this TDT yang clusters tu yang make us
okay, itulah the clusters to clusters that relay the message of residual or early relapse is only when you are dealing with the hypocellular TDT. Very few TDT, but some of them are expressing having the cluster pattern. That would be significant. But when you have a brisk TDT at the background, and then only occasionally you get those cells forming clusters, then we don't really consider it significant. Just like in general pathology, when you have, say, for example, squamous cell carcinoma of cervix, for example, you have the entire cells, 100 cells, are expressing CK56 positive, P40 positive. Suddenly, when you check on adeno components, there are only less than 5% expressing, or 2% expressing adeno component. So we don't call it adenosquamous carcinoma. We still call it as a squamous carcinoma because it's that coexistence is accepted because they are not equal or they are not equal. They are far less. So same principle we use here. When you get the occasional clusters in brisk TDT, then we take the majority pattern.
Okay, thank you, Doctor.
Okay, thank you so much, Dr. Ahmad. Would you like to share the presentation that you were going to share with us, Doctor?
Okay.
Dr. Ahmad, also, if I may ask, if we extend this session by about 30 minutes, is that okay with you? I mean, this is totally...
Okay. Myself will be ready by noon, by 12 o'clock. So okay. This morning, I'm okay actually.
Okay, so maybe if we have gone through your presentation, if you're if there is still time, maybe we can address some of the questions that the participants have asked in the
Okay.
chat box later.
Okay,
Thank
sure.
you.
Boleh.
Yang ni nak share lah.
Ha.
Sini kan.
Oh, okay, okay, okay.
Yang ni.
Okay. Okay. Thank you. Okay. Can you see the slides?
Yes, Doktor, boleh nampak.
Yes, Doctor. Yes.
Okay. This is this slide has been presented to late of last year on what's that? During BMT workshop in UPM. So just a brief on a bit on introduction. Okay, actually, assessing bone marrow evaluation after therapy for hematopoietic lymphoid is very complex. The complexity comes from heterogeneous disease, a different treatment being applied to the disease.
Ahmad, can't see your slide.
Ada. Sekejap ya. Okay, can you see the slide now? Hello?
Yes, Doktor, sorry. Boleh. We can see.
Boleh. Okay. Okay. The okay. Okay, this assessing bone marrow post chemo is quite complicated, quite complex, and that complexity comes from become heterogeneous disease. Heterogeneous because of we know that you have acute myeloid, acute lymphoid, chronic MPD, lymphoma. Then each disease they have different pattern on marrow pattern. So assessing post chemo would also becoming complicated. And then different treatment applied to this different disease. And then we have a different clinical question have to be addressed in your report. And of course, different analysis need to be performed. So we are actually reporting 3 fine biopsy. We are only one portion of those multiple analysis because you have molecular, you have aspirate. The aspirate might be reported by different person. And refined by different person, molecular by another person. So that's the complexity comes from. And okay, Okay, the different clinical question that need to be addressed in the final report, because one is the remission status, whether we have to achieve the report. The report must preferably should be able to say that this is complete remission or partial remission, or your presence of complete or partial remission with minimal residual disease, or patient is having resistant to therapy or relapse after a disease free interval, or in case of transplant they have a rejection of transplant. Then there's the status, and most of us are so confined in this 3.1, that means the disease status, but we forgot the other component, the hematopoiesis, the regenerating status of the marrow, and also any opportunistic infection, and also lastly disease specific changes after therapy, because some drugs that put into the patient may cause dysplastic changes, for example. So we need to mention all those. I mean, we are talking about the ideal reporting, that, but we must also be aware of these changes. If say for example we want to just focus on the disease remission status here in one, not mentioning about the others, fine, because but then if you have a coexisting opportunistic infection, for example fungal infection, coexisting TB infection, for example, then we have to mention that in our report. Okay, this is the different analysis they perform, such as count, aspirate, as biopsy, flow, cytogenetic, and molecular genetic. And clinician is the one who should take all this information and integrate it into the final conclusion. Because we sometimes, like for example, we in the lab, the marrow is being reported by sometimes other team. Flow is another team. Cytogenetic is another lab. Cross the see. Same goes to molecular. Then it will be difficult for us to get everything in our hand before we release our report. That will unnecessarily delay our reports. Okay. So as introduction, the reporting usually actually requires an integrated approach. But what the changes? The changes that we will face in the refine that may influence both hematopoietic and also neoplastic cell is the following. In a post-myeloablative changes include immediate post-chemo changes. You get the myeloaplasia or myelohypoplasia, reduction of marrow fat. So this reduction of marrow fat being replaced by interstitial edema and also fibrinoid necrosis and sinus dilatation, and also relative increase in stromal cell, lymphocyte, plasma cell, and histiocyte. Okay, this is the one that, okay, the classical histiocyte will be very foamy, then it's easy. Even without immuno, you can tell, okay, there are foamy macrophages. This is quite easy. But they are not alone. Normally, they comes together with interstitial edema, fibrinoid necrosis, or proteinaceous material filling the edema, and also sinus dilatation, which you can confirm by CD34. And then this is the sign of marrow recovery. Say, for example, in acute look, for predatory acute look, according to Dr. Rehan, is by day 15, the PITS onco will routinely do the marrow. So that's the time when we see any signs of recovery, that we start to monitor the signs of marrow recovery. Day 15 or after in complete induction. What are the changes of recovery? Reappearance of the fat, okay? And number two, foci of erythroid and granulocytic island will appear on the day 7 to day 10 post-chemo, after completing the chemo, especially in children or after T-cell depleted stem cell transplant. Yeah? And then there will be dramatic increase in precursor B cell. Okay, this dramatic increase in hematogones may vary from patient to patient. Some are really florid that it might be mistaken as incomplete remission. So then describing the pattern, okay, you can say, okay, there are a brisk a population of precursor B cell expressing TDT, but then now describe the pattern. However, majority of these cells, maybe 90% of these cells, dispersed individually without forming clusters. Only very occasional two cell clusters are noted. You can capitalize the word very occasional too, so that clinician overlook on the words too, because we are telling them that this is hematocon. And then if previously patient had fibrosis, one of the signs of marrow recovery is resolution of reticulin fibrosis and the appearance of small megakaryocyte in clusters, like in our last third case just now. The presence of those clusters. And finally, in the standard case, age-adjusted normal cellularity will back to normal in about 4 to 5 weeks after the last cycle of chemo. Okay, the treatment effect. Yeah? Okay. The aim of this treatment effect is a reduction of the side effect of chemo, acceleration of marrow recovery after chemotherapy or stem cell transplant, and also preferably if you know the anti-neoplastic properties, for example, CSF, all those CSF or erythropoietin or thrombopoietin. And remember, and this one will the effect of this will cause induce hypercellularity. The left shift myeloliposis, increased blast, and also mitosis, but actually they are showing maturation. So they will be mistaken as AML or MDS. So we have to compare blast with a treatment blast, whether they are similar or different, and also geographical distribution. Because in patient with the growth factor treatment, the physiological pattern is maintained, whereas in residual disease, the blast population is rather irregularly distributed. This is one of that's why to confirm the immuno will help you not only to semi-quantify those immature cells, but they will also be able to help to appreciate the pattern, whether they are along paratrabeculae when we are talking about AML along paratrabeculae, or they are scattered in between the intertrabecular marrow spaces. And then persistence of aberrant immunophenotype and molecular genetic analysis is helpful because a blast population of more than 5% does not necessarily equal to residual disease. Remember this, but we have to either make some comment in your final report. Please correlate this blast finding with the molecular genetic or IPT as some of these treatment-related blasts can be also be seen, and that's not necessarily equal to residual disease. Okay, you cover yourself, you sort of protect yourself by that statement rather than come up with the final verdict without having some comment, yeah. And then, or else, may also add additional comment that please monitor these features. In growth factor related changes, all those blasts will disappear after 2 to 3 weeks after the last administration. Okay, now we have atypical cells present. How to differentiate between this regenerative atypia versus residual disease? Yeah? To distinguish between reactive or regenerative atypia from persistent MDS, during induction chemotherapy, it is difficult to distinguish residual disease leukemia from hematogons. True. Yes, in our real practice, it can be very, very true. We have encountered in our practice here in KK that sometimes patient on the day 15 when especially pediatric leukemia on day 15 so we have a very brief of TDT positive, then it's very difficult. But then after 1 month or after post chemo, then you see the pattern. The pattern has reduced and the cells are becoming more individual, and they have a classical pattern from 5 to 20 to 34, which is on the decreasing pattern. Megaloblastic. So when you have this kind of situation, probably it's safe to have some comment in your final report after your interpretation. Make some comment. The TDT pattern it's difficult to differentiate residual disease from florid hematogons. Please monitor. Itu je lah. And then megaloblastic changes and karyorrhexis of erythropoiesis are common and can be considered as reactive in the early phase of treatment. So if the dysplasia is already present at diagnosis, so persistent or reappearance suggests residual disease rather than regenerative atypia. Persisting more than 6 weeks after the last chemo cycle is a strong hint for residual leukemia. Okay, this is the morphologic features of inpatient with the transplant, for example. Day 1 to actually 1 month. You take 1 month, you have a pattern of hyperplasia or aplasia, extensive necrosis, proteinaceous debris, fat necrosis, stromal edema, and increased phagocytic macrophages. So when you break down to this pattern, okay, from day 1 to day 10 post-transplant, you have bone marrow regeneration, erythroid and myeloid precede the PK. So you get erythroid and myeloid regeneration first, followed by megakaryocyte. And then by 3rd week, you get increased cellularity to almost 50% of normal. And then by end of month, you get normal. If you are completely engrafted, then you get by 1 month, you get the normal marrow. Okay, if no regeneration is evident after 4 weeks, the hematopoietic stem cell have failed to engraft. So then start to monitor this. What are the changes or pathology that can occur in the after more than 1 month transplantation period? So have to observe for this one: rejection of graft, opportunistic infection. Look for the infection, relapse of primary disease, or you have florid hematogon proliferation. Be careful. This is this one for the. You have to compare number 4 from number 3. Relapse of primary disease, or you get post-transplant myelodysplasia or post-transplant LPD. So be careful. And that's why in post-chemo or post-transplant marrow, the role of to have preferably to have a complete range of IPT is very crucial. Okay, I would talk about this one. Okay, this is the hematogons pattern. When you talk about hematogons, CD10 more than PEX5, PEX5 more or equal to 79A and 79A more than TDT. They have the decreasing pattern of these markers. So you need to have all those marker 1, 2, 3, 4, 5 at least in your report before you conclude that this is a hematogon instead rather than 34, or you get 30 more than 34, but prefer to have 20 and 34 lah. Okay. Okay, hematogons, as we all know that this is a bone marrow B cell precursor. The size and morphology bridge mature lymphocyte and neoplastic lymphoblasts. The large percentage in the healthy infant and young children, but also there are increase in regenerating marrow, patient with autoimmune or congenital cytopenia, patient with lymphoma or neuroblastoma, or even patient with AIDS. Yeah? Okay, this is the pattern. You have many immature cells, but they are slightly different from erythroid colonies because they are rather dispersed from as compared to erythroid. Erythroid tend to be in a colony, but they are here dispersed small cells. But then the nuclear features are rather insufficient to call it as blasts per se because they are quite small and they are quite mildly pleomorphic. Yeah? But when you have the rest of markers, okay, you have many TDT, many CD10, majority of these cells are CD10 positive, indicating they are precursor cells, immature cells. But when you subject to TDT, TDT is lesser than 10, and TDT is slightly more or equal to CD20. Okay. Okay, I will talk this one. I'll skip this slide. Okay. The IAC role, if possible, use the same diagnostic markers in most cases. I mean, when you are making diagnosis, when you are making diagnosis, using you arrive into diagnosis based on that markers. So when you are doing the follow-up marrow, you must using the same markers. So you compare marker to markers and try to quantify positive or negative. If positive, then quantify. But then it's quite different from the LBCL patient with the post-rituximab. In post-rituximab, because rituximab will mask anti-CD20. You don't get you if you are subjected to CD20 on post-rituximab, then you will safely reported as no residual lymphoma cells, when in actual there are some. So you have to replace CD20 with PEX5, CD79A, and compare with CD3 because CD3 probably sort of a guide to indicate when you have florid CD3, likely the patient are responding to rituximab with minimal or without residual lymphoma cells. No? And for monocytic leukemia, it is recommended for this one, CD14, CD163, or CD11C. I'm not sure whether Queen has already get these markers or not. Dr. Nasir has to confirm this one, CD11C. And blast marker, apart from TDT, we use 34 and 117. Okay, morphological evaluation of monocyte and monocyte precursor in bone marrow fine biopsy, a need for establishing diagnostic criteria. Okay, evaluation of fine biopsy for possible monocytic component is particularly sought in the following situation: appreciation of monoblastic features in acute myeloid leukemia or acute monoblastic or monocytic leukemia, and identification and differentiation of CMML from other MPN MDS, yeah? And also subtyping CML into CML1 or CML2, CMML1 and 2. Okay. These are the sort of the importance of monocytic, yeah, because of this necessary. And then on fine biopsy, there are 3 stages of monocytic population that can be identified. Okay, cells with indented. Okay, we have to correlate with morphology. Cells with indented nuclei, absence of nucleoli on CD68 positive. These cells have coarser granule. Okay, this one group of cell. A cell, they are CD68 positive, indented nuclei, and then no nucleoli, they have coarse granules. That's one cell. Another cell is without indented nuclei, but easily identifiable small nucleoli. Okay, they have rounded nuclei, no indented nuclei, small nucleoli, and these cells have finer granule. Okay, coarse granule versus a finer granule, but the coarser one has indented nuclei and no nucleoli. And then the blastic population of cell with extremely fine chromatin and sometimes with marked atypia and greater proportion. This one express CD163 positive as compared to 68. Okay, you make it so 68. Surprisingly, they express more 163 as compared to 6. You can compare. So in this case, in patient, the 3 find of CMML sample, CD68 will identify 2 population of monocytic lineage. CD163 appear to be more reliable marker for early monocytic differentiation and for lineage identification in blastic cell of AMOL. Okay. We are highlighting the importance. So this article, which I took from from article, the status on to have CD163. Okay, a little bit on the discrepancy. The discrepancy between the morphological finding and or interpretation of marrow biopsy and the corresponding aspirate is not unusual, but should be elucidated in an integrative report. An explanation for this discrepancy has to be given. This is to avoid confusion to the clinician, because say for example, you have 2 senior hematopathologists in that particular hospital, and both of them are JUSA, for example, just to make the scenario nampak scary sikit lah, yeah? And then once the one reported the aspirate and the one is reporting the refine. So suddenly you get opposite finding or discrepancy lah. So the second person ataupun each of aspirate or those reporting the refine must always make a comment. Please correlate with refine, for example, yeah. Just like when we report cytology, FNAC versus biopsy. When the biopsy shows lung biopsy shows TB, confirmed with TB PCR, but then the aspirate bronchoalveolar lavage doesn't show any TB or not even granuloma. So always make a comment. Please correlate with the MTB PCR or a biopsy for complete more comprehensive finding lah. So the most common reason for the discrepant result is a heterogeneous distribution of cell, peritrabecular focal growth of blast, for example, or finding they are related to accompanying bone marrow fibrosis. So we have marrow fibrosis. This is as low as grade 1/3, because if you use the tail classification, you have grade O, 1, 2, 3. Okay, grade 1 fibrosis may cause discrepancy in aspirate plus 3 fine, where 3 fine will show more blood cells, and this because of fibrosis, few cells being successfully aspirated. So, in summary, bone marrow biopsy evaluation after therapy in individual patient requires knowledge of the original diagnosis and the clinical history, including the type of prior therapy. Original diagnosis has to be fulfilled the criteria of the WHO classification of hematological tumor. Re-evaluation of original diagnosis biopsy and comparison to the follow-up is crucial. Not all. Sometimes this is when you get suddenly assessing post-chemo, then sometimes in some cases it is important. Yeah? In discrepant cases, as period versus biopsy, re-evaluation of finding is mandatory. I think that's all.
Thank you so much, Dr. Ahmad. This is actually a very educational presentation. And I think we learned quite a lot from this. Can I just ask the participants if are you okay if we just continue a little bit so that we can address the Q&As, or do you want to stop now? Can I have some feedback from the participants?
I think we have another 2 more unexplained question. Maybe we can just
maybe we go through. Okay, Doctor. Okay, so this is from Dr. Zamri. I think Dr. Zamri has a few questions. Okay, which maturation stage in monolineage pick up CD163? The first question. The second question is a cluster that has more than 5 blasts considered a residual leukemic blast and not hematogon? And the third question is which type of CD68 is the best to stain monolineage? Is it KP1 or PGM?
Okay. You have 3, yeah? Okay, the first one was? What was the first one just now?
First one is which maturation stage in the monolineage pick up CD163?
Okay. Actually, in general, 68 will be pen mono. Okay, pen mono, just like 79A for pen B. So they pick up the immature as well as the mature. So CD68 as a pen B. And 163 theoretically will highlight more on the immature one, and as compared to 68. But then in our practice, we do encounter even 68 are so sensitive that they pick up not only this the show expression quite similar to 68, meaning the stain all the, especially in post-chemo, you get the 68 163 also stained. The only thing that we have not really going detail is that comparing the intensity. Intensity of those 163 between the matured versus immature cells, because why we are addressing the intensity, because we learn from angioimmunoblastic T-cell lymphoma, those angioimmunoblastic T-cell lymphoma, the PD1 has to be dark brown, because the T cell surrounding the interfollicular T cell will also be PD1 positive, and they are is we grade as mild to moderate only. So if they are moderate and then the lymphoma cells are also moderate, we cannot call it as angioimmunoblastic T-cell lymphoma. It has to be dark brown staining. So we haven't really observed the intensity of 163 in those matured one. But the articles mention that 163 will stain the immature form. So probably in this case, then we have to add in CD14, because CD14 and 68 will stain different type of cell maturation, monocytic maturation. Okay. Number 2.
Number 2 is which type of CD60 is the best to stay monolineage, either KP1 or PGM?
Okay. Both are equally sensitive for the monocytic lineages, but PGM1 claim to be more sensitive for detecting the immature component. Meaning, if you want to talk about what's that? If you want to talk about AML, monocytic leukemia, for example, then probably you have to use a PGM1 instead of KP1. Yeah, I think that PGM1 is but then this CD68. If you want to have, if you want to have, because normally in the marrow, in the lab, they have only 68. We don't really specify either it's a clone 61 or PGM1, KP1 or PGM1. So you can request that you need to have when you ask for PG1, you ask for the clone PGM1.
I see, Doctor. I think, I'm sorry, this webinar actually has a time limit, so I think
Okay.
already gotten nearing our time limit. So
Okay.
I'm afraid we will not have time to answer all the questions, but don't worry, we've already take note of all the questions. So then we will send to Dr. Ahmad for then Dr. Ahmad can answer in your own time.
Okay, no problem.
Can I invite Dr. Faizatul for last few words, Doctor?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning, everybody. First and foremost, thank you very much to Dr. Ahmad and Dr. Razan for very interesting cases and interesting discussion this morning. So for me, it's definitely a refresher course. And also I've learned some new tips as well. And this will definitely help me when my colleague refer cases to me. All right, and also many thanks to all of the participants who have attended this meeting this morning. And without you, this will not be a success. Okay, and please continue to follow us for the next for the next coming months, because we will continue this inshallah monthly event. Which we found that is very we got a good response from everybody from all over Malaysia. All right, and few last word. We wish that we could invite everybody here to our departments, because both hemato and pathology departments in USM are having Hari Raya celebration today. I know the shower has ended, but this is because of the exam that we had last week. So everything was postponed until today. So those who in HR Pizza, you are most welcome to pathology for Raya. All right, last but not least, again, many thanks and our helpful thank you to Dr. Ahmad, who's willing to spend his precious 2.5 hours with us to teach us about the marrow changes post chemo, and also to Dr. Razan, who has selected interesting cases, and not forgetting my crew behind the scene who has done their marvelous job. Dr. Sarah as an MC, Dr. Sumaya has been handling the technical, and the rest of the team, Dr. Adiba, Dr. Shazwani, and I'm sorry if I didn't mention everyone. And okay, my last word is have a great week and stay safe, and we see you again in the, inshallah, if not June, maybe July webinar session. Assalamualaikum. Back to you, Dr. Sarah.